I hope you can see my screen.
Yes, we can see.
Yes, we can see.
Yes.
I'm going to discuss about a case of a young boy who presented to us with facial swelling and muscle weakness. This was a 14+ years old boy who was previously well, and he was presented to our unit from Tanzania. He has had facial swelling with swelling of the lips and also swelling of the neck and upper chest swelling for about 1 week duration. And this was gradually progressive without any associated leg swelling. But he also had noted a difficulty in breathing without a stridor, and there was no associated fever. There were no history of urticarial skin rashes or any non-significant allergies in the past. He had been apparently well apart from a fever with some upper respiratory tract symptoms about 1 month prior to this correct presentation. He also complained of myalgia, arthralgia involving small and large joints, and also there were painful oral ulcers, but there were no palatal ulcers, no melar rash, alopecia, or photosensitivity or Raynaud's phenomenon. With these symptoms, the patient was admitted to local hospital Tanzania, and he was symptomatically managed with some and basic investigations were performed. So the investigations at local hospital revealed a full blood count basically normal with a slight thrombocytopenia, and he had transaminitis with AST being elevated than ALT, and CRP and other investigations were normal. And since the patient had this facial swelling and upper torso swelling, they have performed the ultrasound scan, which revealed subcutaneous tissue edema in the neck muscles with some reactive enlarged cervical lymph nodes. And even though the liver enzymes were high, ultrasound scan abdomen was normal. So because of this unusual presentation, they suspected the angioedema, and after 24 hours of hospital stay, he was transferred to National Hospital Kandy ENT unit suspecting angioedema. So at the ENT unit, basic blood investigations were done and also managed symptomatically with nebulization, and also some broad spectrum antibiotics were started. And further assessment at the neurological ENT unit revealed the weakness of the upper and lower limbs. So further questioning has revealed that he has had this weakness over about 1 week period with the development of this facial edema. So with these findings, they have referred the patient to neurology unit, and they took over the patient for further management. So at the neurology unit, this boy was found to have gradually progressive proximal predominant muscle weakness, and that weakness had been progressive and has involved neck muscles as well. And there was associated difficulty in breathing also. On general examination of this patient, he was afebrile, not paleoicteric. There were no clinical detected lymphadenopathy. There were no cutaneous features of SLE or dermatomyositis. And he had lip, neck, facial, and upper chest swelling. There were some superficial oral ulcers of the lips and buccal mucosa without any palatal ulcers. This is the picture of our patient. Unfortunately, I don't have the first presentation of this patient, the pictures, but I hope you can appreciate the difference with the first picture with the second picture, where there is significant edema of the face with swelling of the neck and the upper chest area compared to this second picture, which was taken about 3 months after hospital admission. So musculoskeletal and neurological examination did not reveal any active synovitis, even though he complained of arthralgia, but there was some muscle tenderness, and there was significant proximal muscle weakness compared to distal muscle weakness in the upper and lower limbs. Shoulder muscle weakness being about 2+, and hip about 2+, and also at elbow and knee, it is about 3+. He had some small impairment of the distal muscle weakness as well, and there was significant impairment of the knee, neck flexion impairment than the extension. He also had a waddling gait, and he had some contractures of the bilateral elbows. His GCS was 15 out of 15, and respiratory system examination, apart from poor chest expansion, it was normal. And abdominal examination and cardiovascular system examination was normal. So the further investigations revealed a full blood count with some leukocytosis with a slightly low platelet, which corrected gradually. And his blood picture revealed a moderate ruler formation with some leukocytosis, suggestive of evidence of infection or inflammation. He had a high ESR of 42, but his CRP and procalcitonin levels were normal. With this muscle weakness, he had a very high creatine phosphokinase level, initially 39,700, which went up to about 6,800 during the hospital stay. He had markedly elevated liver enzymes with high AST levels and also slightly elevated alkaline phosphatase and gamma GT levels, and also slightly low total protein with normal albumin-globulin ratios. So to exclude any endocrine cause of muscle weakness, the thyroid profile was done, which was normal, and the electrolyte panel was normal, apart from slightly low ionized calcium with slightly high serum phosphate with positive urine for myoglobulin, which was suggestive of some underlying rhabdomyolysis. But his UFR and chest X-ray was normal. So with this initial presentation and the investigation suggestive of a myositis, this patient was managed as a possible inflammatory myopathy. So he was started on IV methylprednisolone 1 gram per daily for about 3 days, followed by high-dose oral prednisolone with bone and GI protection. And meanwhile, we were able to get done the EMG, which showed evidence of severe generalized myositis, which further confirmed the diagnosis. But while on the second day of IV methylprednisolone, he further had a worsening weakness with dysphagia. So NG feeding was started, and because of this worsening weakness, he was started on IV immunoglobulin 2 mg per kg dose given over 3 days. At this point, he was referred to rheumatology opinion, and the combined management started with the neurology team. So we also agreed with the management with IV methylprednisolone and IVIG, and muscle strengthening exercises was also started. So at this point, we considered the differential diagnosis for this patient. So the first differential diagnosis we thought of is whether this could be inflammatory myopathy, either juvenile dermatomyositis, even though he did not have the classical clinical features of cutaneous manifestation of juvenile dermatomyositis. He had this significant facial swelling and proximal muscle weakness. The other differential diagnosis we considered was juvenile polymyositis with a possible overlap of systemic lupus erythematosus because of these oral ulcers and the arthralgias he mentioned. And also we considered about vasculitis and also viral myositis. Apart from this common viral etiologies which cause myositis, since this patient presented during the pandemic of COVID-19, we considered COVID-19 causing viral myositis also. So then we went ahead with further investigations. We wanted to get an MRI proximal muscles, but the initial stage, it was unfortunately we could not able to done because of the limited availability. One time the patient was given a chance, but he fainted at the MRI room and it was unable to get it done. So we went ahead with a muscle biopsy, which again did not reveal any abnormalities of inflammation. It was normal. Then to look for any cardiac involvement, we did a 2D echo, which was normal. And since the patient had this persistent dysphagia, they have done an upper GI endoscopy also, which was normal. And because of this suspicion of SLE, we did an ANA, which was negative, and complements levels were also normal. And with the suspicion of inflammatory myopathy, anti-Jo1 antibody was done, which was negative. And from the viral serologies, EBV, CME, Coxsackie-AB viral serologies were negative. Because of the suspicion of COVID-19, with the initial history of his fever with upper respiratory symptoms, we did the rapid antigen and PCR, which was negative, but he had a positive COVID-19 IgG antibody levels. So we know Coxsackie-B and other viral etiologies can cause myositis, but can COVID-19 cause myositis? Yes, now it's well known. There are reported case reports with very high CPK levels with proximal myopathy. The COVID-19 can present, but the difference is they present with the acute infection of the COVID-19, unlike in our patient who had only positive COVID-19 IgG antibody levels. So at this point, we took a dermatology opinion regarding the oral ulcers, but it was suggestive of a mucositis and it was managed with doxycycline and nystatin mouthwash. And while on methylprednisolone therapy, the patient had a blurring of vision of both eyes, which he developed overnight. So we referred the patient to the ophthalmologist, where they detected the drastically reduced visual acuity in both eyes. And the fundal examination reveals multiple cotton wool spots and splinter hemorrhages scattered in the posterior pole of the retina, suggestive of a Purtscher-like retinopathy. This is the fundal photograph of our patient. And I hope you can remember this is a classic textbook picture of the Purtscher-like retinopathy, where there are multiple cotton wool spots and splinter hemorrhages. Just to remind you what is Purtscher-like retinopathy is, it's a hemorrhagic and vaso-occlusive vasculopathy. It is usually described with head trauma, which is when we describe it as Purtscher retinopathy. It occurs due to retinal vessel occlusion. Then there can be infarct to the retinal capillary bed. But it is associated with acute pancreatitis, fat embolism also. And in rheumatological point of view, it is associated with juvenile dermatomyositis, SLE, and scleroderma. And in these cases, we call it Purtscher-like retinopathy. So at this point, we considered the diagnosis of juvenile dermatomyositis of this patient, even though he did not have these classic clinical features of dermatomyositis, because the pathogenesis of the juvenile dermatomyositis, it is a vasculopathy, and this Purtscher-like retinopathy is also a vasculopathy. And he had this facial edema and also the proximal muscle weakness, which further confirmed our diagnosis. So just to remind you whether we have come into correct diagnosis. So these are the major causes of myopathy. So out of inflammatory myopathies, the dermatomyositis, polymyositis, and vasculitis and the overlap syndromes. And we have excluded hypothyroid out of endocrine causes and the electrolyte abnormalities. And infections, we excluded doing basic viral etiologies. And for the rhabdomyolysis, even though he had a slight rhabdomyolysis, there was no other precipitating cause for develop this much of a proximal muscle weakness. So still, can we call it as dermatomyositis? Dermatomyositis is a clinical diagnosis, but I hope you can remember the Bohan and Peter classification criteria, which was more of adult inflammatory myopathies, described in 1975. Where they included this proximal muscle weakness and the elevated muscle enzymes and the EMG findings and the muscle biopsy findings and the typical cutaneous features of dermatomyositis. But in 2017, there was a EULA-ACR classification criteria for both adult and juvenile idiopathic myositis, where they have two arms with a positive muscle biopsy and without a muscle biopsy. They included the age of onset, the muscle weakness, and the characteristic dermatomyositis skin findings and dysphagia, and also the laboratory measurements and also muscle biopsy findings. So in the absence of a muscle biopsy, if the score is more than 7.5, it is classified as definite idiopathic inflammatory myopathies. If the score is more than 5.5, it is probable inflammatory myopathies. So at this point, in the absence of classical cutaneous features, our patient had a score of about 6.1, claiming the probable inflammatory myopathy. So our patient had a negative muscle biopsy. So can it be negative? Yes, in about 10 to 20% of muscle biopsy can be normal in idiopathic inflammatory myositis due to sampling errors due to skip lesions. And also steroid therapy before taking the muscle biopsy, even though our patient, we took it in the first week of steroid therapy. And to avoid this, we can do MRI and EMG to detect active areas of muscle inflammation. So our patient, while he was on treatment, his CPK levels were persistently high. So because of that, we observed the patient in pediatric ICU for about 2 days. And with the nephrology opinion, we did alkaline diuresis because of this high CPK levels for about 2 days. And he was started on methotrexate 7.5 milligram with folic acid supplements once the liver enzymes were dropped, and it was gradually increased to 10. And also physiotherapy with muscle strengthening exercises were continued. And his swallowing was assessed with speech and language therapist, and it was suggested to continue the NG feeding. So response to treatment of this patient, his muscle weakness was improving and the muscle enzymes drastically came down to 997 on discharge after about 1 month of hospital stay. His muscle weakness also improved in upper and lower limbs up to grade 3+ and 4- in the lower limbs. But his dysphagia was persistent and his visual acuity was completely improved. And he was followed up in the neurological clinic with oral prednisolone, and it was tapered to about 30 milligrams after about 6. So then later on, this patient readmitted to medical unit after about 1 month of discharge with fever without any worsening muscle weakness or cutaneous features. And this was managed as aspiration pneumonia. So at this point, we took the patient over for our care after recovering from the infection for further management and rehabilitation. So we continued the oral prednisolone 30 milligrams with MTX, and it was gradually increased to 50 milligrams per week. And since the patient had persistent dysphagia, we again reconsidered the possibility of an MRI. We were able to get only MRI brain with pharyngeal muscles, where it showed the enlargement and high T2 signal changes in the lateral pterygoid muscles and pharyngeal wall muscles and muscles of mastication, suggestive of myositis. I hope you can see the MRI, where there are enlarged lateral pterygoid muscles with some high signal intensities in those muscles, suggestive of active muscle inflammation. So the progression and further management of this patient after further following assessment, since the patient was on an NG tube for about more than 2 months, we got with the GI opinion, we got the PEG tube inserted, and nutrition was optimized with the input from a nutrition team, and his intensive inward physiotherapy was given. But since the patient had a persistent dysphagia and a static improvement in proximal muscles, we started the patient on monthly IVIG therapy, 2 milligram per kg dose over 3 days, and plan to give it monthly. Even though we tried to overcome this muscle weakness, from the patient point of view, he had poor motivation. So we did a psychiatric referral, and he was diagnosed as having adjustment disorder with depression, and he was started on counseling, and oral mirtazapine was also started. With this, most of his lack of motivation was improved, and he was more enthusiastically engaged in physiotherapy. After about 4 months of the initial presentation, during one of the ward admissions, we noted the patient again found to have eyelid swelling with a faint violaceous rash over the eyelids, and also in the nails he had ragged cuticles in the fingers. So we suspected a heliotrope rash, and we took a dermatology opinion. I hope you can appreciate the periorbital edema of this patient, and even though it's not very obvious, there's a slight faint violaceous macules over the upper eyelid suggestive of heliotrope rash. And these are the ragged cuticles which he had developed over the last 4 months. So dermatologists also confirmed the findings, and also we requested a nail fold capillaroscopy which showed evidence of dilated nail fold capillaries. So since there was active disease, we started him on oral cyclosporine therapy, 3 milligram per kg, while monitoring the levels. And with this combination treatment with MTX, IVIG, and cyclosporine, he had a marked improvement in the proximal muscles as well as in dysphagia after 1 month of the combination treatment. So we gradually tapered the steroids 10 milligram per day, and his proximal muscle power improved to 4+ in the upper limbs and 4 in lower limbs. And his dysphagia fully improved, and he was able to swallow both liquids and solids. And we are planning to take out the PEG tube. But with this patient, even though he improved with this treatment, there were a lot of problems with regard to the rehabilitation, because there was poor social background of this patient with lack of support from the father, and mother was unable to stay for the physiotherapy in the ward because of another brother who was awaiting O-level examination and having some behavioral issues. And being a teenage and with this depression, and there was problems with regard to rehabilitation, but with teamwork, we were able to overcome these difficulties. So our patient is an atypical presentation of juvenile dermatomyositis, and it's a rare finding to have this Purtscher-like retinopathy. It's rarely described in world literature, and I could not find any Sri Lankan case reports of Purtscher-like retinopathy in juvenile dermatomyositis. So let me talk about juvenile dermatomyositis in brief. So we all know about these classic clinical features, the heliotrope rash, the protuberance papules. But in children, they can have extensive skin ulceration compared to adults, and they can have extensive skin calcinosis as well. There are other less common clinical features like this mechanic hand, shoal sign, and V sign are less common in children, but they can have lipodystrophy, and later on they can develop insulin resistance and type 2 diabetes in this patient. And previously described Purtscher-like retinopathy is also a very rare presentation. So there were a few case reports I could able to find with association of dermatomyositis with Purtscher-like retinopathy. And the pulmonary involvement in this dermatomyositis is less common than in adults, but they can present with ILD. Certain levels of autoantibodies like MDA5 antibodies, IL-18 antibodies are associated with rapidly progressive ILD in these patients. They can have non-erosive arthritis and arthralgia, and joint contractures like in our patient can occur due to muscle inflammation. So the GI vasculopathy, it is rare in children, but it is life-threatening. They present with abdominal pain, pneumonitis intestinalis, GI bleeding, perforation, etc. They may occur late in the course of the illness or with mild myositis also. And the anasarca, or the generalized body edema, is a rare presentation of JDM. It is due to capillary leak from the vascular endothelial damage. So this presence of anasarca at the presentation is a poor prognostic sign with slow response to treatment. But the subcutaneous edema is common, though we fail to appreciate it clinically. And it can be associated with fascial inflammation, and it predicts the development of calcinosis. There were case reports with juvenile dermatomyositis mimicking a presentation of angioedema like in our patient. Sometimes there are true association of juvenile dermatomyositis with hereditary angioneuritic edema, where there is C1 esterase deficiency. In our patient, although the C3, C4 levels were normal, we tried to get a C1 esterase level done, but it was unable to do at the MRI also. So to diagnose, it's a clinical diagnosis, and I have already discussed the classification criteria, but there are specific tests. To assess muscle strength, we can use the MM8 score or the confrontational muscle strength testing score. And there is this childhood myositis assessment scale or the CME scale. It is an objective assessment of muscle strength where you give a score of 0 to 51 to assess certain activities of a patient. So nail fold capillaroscopy is also helpful. There can be dilated nail fold capillaries, tortuosities, and dropouts. And this abnormal nail fold capillaroscopy findings correlates with the skin involvement in several studies. So the muscle enzymes, the CPK, elevated AST, LDH aldolase also supportive. And the MRI plays a big role, especially in children. MRI full body or MRI proximal muscles, used increasingly to avoid muscle biopsy in childhood inflammatory myopathies, and also to diagnose and follow up, especially T2 weighted MRI and fat suppressed sequences. So the edema is noted that the inflammation is noted as edema and high intensity signal intensities. So EMG, they have characteristic findings in juvenile dermatomyositis and juvenile polymyositis with spike and wave abnormalities. They help to distinguish the changes due to muscle denervation and inflammatory myopathies. But as I said earlier, can be false and negative due to patchy involvement. The muscle biopsy to differentiate between dermatomyositis and polymyositis. In dermatomyositis, there is perivascular inflammatory infiltrate with perifascicular atrophy, and in polymyositis, there's endomysial inflammatory infiltrate. So there are myositis-specific autoantibodies. Those are associated particular clinical syndromes, but the sensitivity is less, 20 to 40%. So the negative doesn't exclude the diagnosis. So these anti-synthetase antibodies directed against tRNA synthetase. The anti-Jo1 is the commonest anti-synthetase and commonest myositis-specific antibodies. It is seen in about 20% of patients and is associated with ILD, Raynaud's phenomenon, mechanics hands. And this anti-PL2 is also associated with ILD. This anti-SRP antibody is associated with necrotizing myositis with severe treatment-resistant disease. And we all know this anti-MDA5 antibody is a rapidly progressive ILD, cutaneous ulcerations, and arthritis with less muscle weakness. So there are myositis-associated autoantibodies also. they found when there is a systemic rheumatic disease associated with the myositis, like the presence of anti-roller antibodies and ANA, which is present in about 60% of patients with inflammatory myopathies. Then how to manage the duodenal dermatomyositis? The goals of treatments are to control the inflammatory myositis and to prevent and treat the complications like calcinosis and contractures. So this management depends on severity of the disease. So what is our guide to management? So there are few data from randomized controlled trials. So the treatment approach is mainly based on the observational studies and clinical experiences. So there is some guide from this 2008 survey of North American pediatric rheumatologists where they recommended the combination of steroids and MTX therapy, and the recommendations from CARA and SHARE guide recommendations, and also the Sprinto recommendations where they describe double steroid tapering and regarding the inactive disease. So in a mild to moderate disease, we can start oral prednisolone 1 to 2 milligram per kg per day in divided doses, and methotrexate 15 to 20 milligram per square meter per week. And we expect to see an improvement within 6 weeks with normalization of muscle enzymes and the improvement of cutaneous findings. IV methylprednisolone can be used in mild to moderate disease with poor response while on oral treatment or if they develop worsening symptoms. So as steroid sparing agent, MTX is the first line, which we can use as oral or subcut. And there's a place for cyclosporine, but we usually use this when there's refractory disease, but in some cases we use in early disease as well. The dose is 3 to 5 milligram per kg, but we have to keep an eye about the side effects like ginger hypertrophy, hirsutism, etc. And there is some place for MMF for both skin and muscle involvement. So this is the SHARE recommendation summary for the management of mild to moderate juvenile dermatomyositis. So at the onset of the disease, we can start with oral prednisolone combined with methotrexate. If no improvement, there's a place for either adding IVIG or change to cyclosporine instead of MTX or MMF, or going ahead with a biologic like TNF alpha inhibitors like infliximab, or to change to rituximab. So severe disease is considered as when there is involvement of lungs, ILD, ulcerative skin lesions or GI tract involvement, when there is GI vasculopathy, and also myocardial and neurological involvement. So in severe and life-threatening disease, we can use IV methylprednisolone pulse therapy, 30 milligram per kg per day, maximum 1 gram for 3 days, followed by high-dose oral prednisolone. There's a place for IV cyclophosphamide for severe and refractory cases. So the doses they have used is IV cyclophosphamide 500 milligram per square meter every 2 weekly 3 doses, followed by 750 milligram per square meter every 3 to 4 weekly, and total dose of about 6 doses. And in refractory and recurrent diseases, there's a place for IVIG as additive treatment to treat control and persistent or recurrent symptoms and to reduce the cumulative dose of glucocorticoids. These are based on several observational studies and can be given as a dose of 2 gram per kg as a single dose, followed by 2 weekly 5 doses, and can be given monthly up to 2 years. So usually this IVIG is used after the initial months of the initial diagnosis when there's poor response, but can be used in early course of the disease in severe disease. And there's a place for cyclosporine, as I discussed previously, in refractory cases. So there's a place for biologics. Rituximab has shown some benefit in small case series, and there's a place for TNF alpha inhibitors, infliximab and adalimumab as steroid-sparing agents, and also to improve the muscle disease. And there are some case reports of using abatacept as well. And less evidence for MMF, tacrolimus, and HCQ also is there. So this is the SHARE recommendation summary for the severe disease and refractory disease. At the onset, we can start IV methylprednisolone with MTX, and if there is severe disease, if not improving the initial therapy, we can consider changing over or adding to cyclophosphamide pulse therapy. Still, if there is no improvement, we can go ahead with either rituximab, anti-TNF alpha therapy, or we can use the combination treatment that we use in our patient, the high-dose MTX, cyclosporine, and IVIG. So when to stop the therapy? So we gradually tail off the steroids, and if the patient is in a remission or without steroids for about 1 year, we can consider tailing off or stopping other DMARDs. So this is again the share recommendations that I described earlier. The adding of high-dose steroids with MTX and the place of cyclosporine, and also the use of IVIG, and also the place of rituximab in severe refractory cases, and the anti-TNF alpha therapy for these patients. So this is my patient. About this page, this picture was taken 4 weeks back. Currently, the patient is on prednisone 10 milligram per day. As a steroid sparing agent, he is on MTX 15, cyclosporine, and also monthly IVIG therapy. Currently, he is independent on ambulation, grooming, and feeding, and we are planning to take this spec tube out. So my take-home message out of this case is the juvenile dermatomyositis should be suspected in young patients presenting with proximal muscle weakness, even in the absence of typical cutaneous features. And this Purtscher-like retinopathy is a rare finding in juvenile dermatomyositis, and JDM can present mimicking angioedema, and treatment-resistant patients should be identified early, and the treatment should be intensified early to have a good outcome. So these are my references, and I would like to extend my thanks to my trainer, Dr. Tilakamayan Nisanka, consultant rheumatologist, and also to Dr. Janaka Pires, the consultant neurologist at National Hospital Kandy, and also to Dr. P. Sriharanathan, who's the consultant vitreoretinal surgeon who diagnosed the Purtscher-like retinopathy and who provided me with the pictures, and also to my patient and his mother for giving the consent to provide this information in this presentation. And thank you all for your patient listening.
Thank you very much, Chandima. It was a lovely presentation and it's very timely. And I think we see a wide spectrum of post-COVID infections, post-COVID syndromes these days, and this is an eye-opener. Thank you very much. And if there are any questions, at least a couple of questions we may take up.
Thank you.
In fact, one participant, perhaps from UK, said that they have experienced post-COVID vaccination myositis. That is also interesting, and we will be seeing a lot of these kind of cases in future as well.
Yes.
Thank you again, Chandima. So we'll move on to the next talk. It is done by Dr.